Assalamu alaikum. I'd like to thank the organisers for inviting me to speak to you today. So I'm an ID physician by trade, practicing in Scotland, and I approach this with a very specific slant, but I will be hopefully chatting through the concept of pneumonia in the immunocompromised patient, and that includes all kind of patients with immunocompromising conditions, be it primary immunodeficiency, transplants, or acquired immunodeficiencies like HIV infection. So we'll have a bit of discussion around the definitions and what actually is defined as pneumonia in the immunocompromised patient, a bit of discussion about the immunodeficiencies and what to consider in terms of pathogens that are associated with particular aspects of immunodeficiency, the differential diagnosis, which is broad, and the diagnostic approach, how you should think about the patient that you see who has pneumonia in the context of underlying immunodeficiency. And then I will discuss a bit about the management, and that is quite subtle, quite nuanced. It is not one size fits every patient. And then I will also discuss some specific entities, so some specific conditions and causes of pneumonia in immunocompromised patients that we see, and some of the controversies or uncertainties in those conditions. So what defines pneumonia in the immunocompromised host? So these are kind of definitions that were set out by the American Thoracic Society. And the whole concept is around a presumed infectious pneumonia occurring in an individual who has a functional host immune defense disorder. And you need to have a suspicion of lung infection with or without compatible clinical signs and symptoms, or radiological evidence of pneumonia. So either be a new infiltrate on chest radiography or a worsening pulmonary infiltrate. It should be noted that some of the patients that are excluded from the American Thoracic Society definition include patients with cancer who don't have profound leukopenia, who don't have immunoglobulin defects, and patients who are not receiving systemic anti-cancer therapy. So they're not included within this group because they are not regarded as being immunocompromised enough. Other patients that we see that do have systemic conditions that do affect the immune system, so those with cirrhosis or diabetes, are also not included. And patients with underlying structural lung disease, so chronic obstructive pulmonary disease, bronchiectasis, etc., are again not included within this underlying kind of phenotype. So what do they define as immunodeficiency? So it's basically these conditions here, or these list of entities. So it may include cancer or hemopoietic stem cell transplant patients. It may include patients with HIV infection and resulting immunocompromise. Chronic immunosuppression as a result of, for autoimmune or inflammatory disease, including novel biologic treatments, of which we know there are many. Solid organ transplant recipients. And primary immunodeficiency syndromes, which are rare, but we do see in clinical practice from time to time. One thing I will say is that immunodeficiencies are not equal. So there is this concept, obviously, all immunosuppressive agents have a different mechanism of action and different effects on the immune system, and they may affect different arms of the immune system. So, for example, there's this concept in transplant infectious diseases around the concept of the net state of immunosuppression. So how immunosuppressed is the patient? And it is a spectrum from profound immunosuppression post-hemopoietic stem cell transplant to patients on relatively modest mycophenolate or prednisolone at lower doses. The spectrum of immunosuppression is quite marked. So that is something that is worth considering, because that may give you a feel for what conditions to more suspect, depending on the underlying immunosuppression. So if you have defects in the humoral immunity, you are much more likely to experience infections with bacteria, particularly encapsulated bacteria. Innate immunodeficiency lends itself much more to bacteria and kind of nocardia and fungi, particularly Aspergillus and mucormycosis, and we see that a lot in the hematological or hemato-oncology setting with patients with profound neutropenia. And in patients with cellular immunodeficiency, we see viruses, mycobacteria, so TB and non-tuberculous mycobacteria predominate, and other fungi, particularly Pneumocystis jirovecii, along with some parasites. So how does pneumonia differ in the immunocompromised host? Well, I think first of all, we all see patients with community-acquired pneumonia, but pneumonia in the immunocompromised patient has a much broader range of possibilities, and it presents a bit differently from those with a competent immune system. The symptoms may be non-specific, and they may appear relatively well initially, progressing to fulminant infection. The chest X-ray may be normal, and this is particularly in the case of neutropenic patients where CT scan really is a critical investigation as part of the diagnostic workup. So what is the differential diagnosis? So this is not completely exhaustive, but this encompasses probably the most common things that we should consider as part of the initial workup for pneumonia in the immunocompromised patient. So obviously bacterial infection, particularly encapsulated bacteria that we see commonly as part of our day-to-day practice. Both TB and non-tuberculous mycobacteria should be considered, and again, in patients with profound immunodeficiency, we may see dissemination of NTM. Legionella and nocardia, which is a kind of non-filamentous organism that again causes infection in patients with significant deficiencies in innate immunity, are other bacteria that should be considered. And viruses are, legion in the cause of pneumonia in the immunocompromised patient. So particularly herpes viruses, so herpes simplex virus types 1 and 2, cytomegalovirus, varicella zoster virus, and HHV6 can all cause pneumonia. And our standard respiratory viruses that we see day in, day out, so influenza, SARS-CoV, RSV, and adenovirus. In terms of fungi, the list is slightly smaller, and the most common ones that we see are Pneumocystis and invasive aspergillosis, and less commonly we may see others, mucormycosis, cryptococcosis, and histoplasmosis. Some of those may vary in terms of the areas in which you practice. And parasitic infection is rare, but is something that we see particularly in the context of things like corticosteroids in the case of strongyloides. So the diagnostic approach is fairly kind of extensive, and if you like, these are suggestions made by the American Thoracic Society in 2023 for what they perceive to be bronchoscopic investigations, but the initial test should probably be a CT scan of the thorax to provide radiological clues to the diagnosis, and also to provide if you like, steer for targeted bronchoscopy and deep sampling to provide definitive diagnosis. Now, a lot of these tests that the American Thoracic Society recommend are complicated and not available. And certainly, in my experience practicing in the UK, we don't have access to a lot of these tests. But these are, and I think in an ideal world, if we had availability to every test possible, these are the tests that are recommended as being part of the diagnostic workup for patients with pneumonia in the immunocompromised state. So you will obviously include your standard bacterial culture, but also doing extended culture for things like nocardia and Legionella. You will do mycobacterial testing, so smear mycobacterial culture and PCR, such as GeneXpert, if you have that available. You'll do fungal culture, and looking for things like Aspergillus. You will ask for stains and PCR for Pneumocystis, if that is available in your centre. You ideally will do tests for additional tests for Aspergillus, so that might include Aspergillus antigen, galactomannan, or PCR, along with PCR testing for other respiratory viruses, so be it SARS-CoV, influenza, adenovirus, etc., and herpes viruses. And cytology is a critical part as well, because that may give you a steer that sometimes in patients who are immunocompromised, they're not just at risk of infection, but they may be at increased risk of malignancy. And so cytology is a useful additional investigation. This is just I found this in a review article that was quite helpful as a non-respiratory physician for reminding me about the extent and the differential diagnosis depending on the findings that may come across in cross-sectional imaging in the immunocompromised patient. And again, it may help you narrow down your suspicions around what entity you are is highest on your list of differential diagnoses. But it is rare, even from imaging, to have a single diagnosis in mind in a profoundly immunocompromised patient. So, what treatment should you consider? And I think that's a complicated question, and it depends on a number of factors. You want to consider the underlying host immune defect, how immunocompromised they are, what are the clinical findings, and how severely ill they are. If they are very mildly ill, you may have some time to undertake some tests before rushing in with empirical treatment. We know that empirical treatment, particularly in fungal infection, can drastically reduce the chance of getting definitive positive microbiological samples. So sometimes empirical treatment may actually harm the chance of you getting a definitive diagnosis from your deep sampling. An empirical regimen that will cover all possibilities is pretty much impossible. And it may involve multiple drugs that may be toxic, complicated to administer, and expensive. And so that is not always feasible. And you also need to consider your own local resistance patterns. Obviously, the spectrum of resistance, both in terms of bacteria and fungi, ranges across the world. And so some places, there may be additional considerations that you require when selecting an antimicrobial regimen. So empirical treatment considerations. So these are my thoughts around how you might build a treatment regimen depending on severity of illness in a kind of stepwise fashion, starting with initially an antibacterial agent, so a broad-spectrum beta-lactam like a carbapenem, and depending on your own local epidemiology, you may choose the addition of an anti-MRSA agent, be it vancomycin or linezolid, depending on what you have available in your particular centre. I think the first additional agent I would probably add in an immunocompromised patient would be trimethoprim sulfamethoxazole at high doses, and this is particularly active against Pneumocystis jirovecii, and also is very active against nocardia, which carbapenems will have some activity against as well. Depending on imaging findings, you may want to add an antifungal agent, and if you are strongly suspicious of invasive aspergillosis, an azole like voriconazole would be the agent of choice, although amphotericin B may be useful if you have additional concerns around, for example, mucormycosis or some of the other fungi such as Cryptococcus or histoplasmosis. Generally speaking, antivirals and antimycobacterial agents do not necessarily need started empirically, and it will often be helpful to get samples before starting treatment, because again, that might also alter so that the likelihood of getting a positive diagnostic result. So I will now discuss some specific entities, because there's a couple of controversies around some of these conditions, and these are specific conditions that I don't think other speakers are specifically talking about. So I thought I would discuss particularly Pneumocystis jirovecii, which is probably one of the more common kind of entities that we see in immunocompromised patients. I'll talk a bit about invasive aspergillosis, and if I've got time, I will talk a bit about nocardiosis, which is rare, but is quite a complicated infection that we often see in some patients who've got profound immunodeficiency. So, Pneumocystis jirovecii pneumonia, this is a ubiquitous fungus, which is we are commonly colonized with this, and we do see that there have been outbreaks and transmission of pneumocystis in healthcare settings. It is now, despite its origins, it is now much more common in non-HIV patients than HIV patients. And some of that is probably to do with the burden or the overall global burden of HIV patients being diagnosed and started on treatment and the effectiveness of antiretroviral therapy. So in particular, in solid organ transplant patients and hemopoietic stem cell transplant patients, Pneumocystis jirovecii is a major cause of respiratory infection. The highest risk is in those first 6 months post-transplant, although you can get it at any time. Illness phenotype interestingly, is much more severe in the non-HIV patient population. The mortality rates are essentially about double what we saw in the kind of the kind of HIV era when pneumocystis was a widespread entity. And the major risk factors in patients who are immunosuppressed include lymphocyte depleting agents, so be that anti-thymocyte globulin, rituximab, etc. High steroid doses, so if you've been on more than 20 milligrams of prednisolone for at least a month. Cytomegalovirus, rejection, or lymphopenia. The diagnosis is complicated to make, and the imaging is not particularly discriminatory. There's a lot of ground glass opacities. You may get some thickened septal lines, and you sometimes get cystic formation on CT. Now, immunofluorescence used to be the test of choice from bronchial alveolar lavage, but pneumocystis PCR has kind of superseded that and is far more sensitive. And on bronchial alveolar lavage is well in excess of 90%. Indeed, it's probably in excess of 95%. Induced sputum being PCR is much lower. It's about 30 to 55% in the literature. Histopathology, if you take samples with lung biopsy, the sensitivity is more than 95%, but obviously that is not a procedure that you will undertake easily in an acutely unwell immunocompromised patient. And the literature has built on other tests that may support diagnosis of pneumocystis, including beta-D-glucan. And while these are very specific, they're not sensitive and they're not helpful to diagnose really the condition, but they might help rule it out. So there's discussion around the, if you like, diagnostic criteria in non-HIV patients, and they're, a probable case. This is from Clinical Infectious Diseases, a consensus statement where you have, the presence of a host factor, a clinical features compatible with pneumocystis jirovecii, and mycological evidence, and that is normally, maybe you kind of using either beta-D-glucan to support the diagnosis along with imaging, or detection of pneumocystis itself. The primary treatment recommendations have pretty much been the same for decades for pneumocystis jirovecii, and that includes high-dose trimethoprim sulfamethoxazole, normally given at a dose of about 20 milligrams per kilogram of the trimethoprim component, and that's divided in doses throughout the day. And the duration has been quoted as being 21 days for HIV-associated disease, although a lot of guidelines looking at patients in the hematology setting may suggest at least 14 days as a minimum. And adjunctive steroids are suggested for moderate to severe disease, so patients who are significantly hypoxemic, although the guidelines in hematology patients suggest that steroids are not routinely used, and I'll talk about that in a minute. The data for trimethoprim sulfamethoxazole in pneumocystis jirovecii is really old. There are only 14 randomized controlled trials. The average number of patients in these trials is about 100, and these are almost exclusively conducted in relatively young men with HIV infection. There's actually no real proven superiority of treatment. We just know that atovaquone, which is one of the comparator agents, appeared inferior to trimethoprim sulfamethoxazole, and there is significant uncertainty around what the best duration of treatment is and also the dosing. So this has been raised in recent years, despite the fact that we still use extremely high doses of trimethoprim sulfamethoxazole. Colleagues in McGill University in Canada recently conducted a meta-analysis looking at the difference in outcomes in patients with low dose versus high dose trimethoprim sulfamethoxazole. And the outcomes looked relatively similar, but with significantly less toxicity when you administer lower doses of trimethoprim sulfamethoxazole. So this dogmatic practice of using extremely high doses of trimethoprim sulfamethoxazole is probably archaic and needs reviewed. Adjunctive steroids, as I mentioned before, in a meta-analysis, actually the benefit is primarily in patients who are hypoxemic or have respiratory failure, not in all patients. So steroids should be used with care and kind of applied to patients who have evidence of severe disease rather than kind of milder PCP. So in summary, from my thoughts on pneumocystis, current practice is really outdated and goes back to the 1980s, 1990s even in terms of some of the evidence. And the original recommendations are adapted from HIV, but really need to be brought up to modern times to reflect the patient population we're treating. The patient groups are not the same, and extrapolating just directly from HIV does expose patients to risk. I'll briefly speak about invasive aspergillosis now. We'll all have seen cases of invasive aspergillosis, majority due to Aspergillus fumigatus, and antifungal resistance is rising, and most of that is due to antifungal use in agriculture. Interestingly, a lot of patients with invasive aspergillosis in the profound kind of neutropenic setting will not have much in the way of respiratory symptoms, and they may just have unrelenting fever that is refractory to antibacterial therapy, and that highlights the importance of urgent CT scanning in these patients. Invasive aspergillosis is strongly associated with depth of neutropenia and duration of neutropenia. So profound neutropenia for more than 10 days is strongly predicted of invasive aspergillosis. So patients with high-risk MDS, acute myeloid leukemia, or post-hemopoietic stem cell transplant are much more likely to develop invasive aspergillosis. But it is well recognized in other groups, heart, lung, and lung transplant recipients particularly. And like I said, the risk varies between different conditions. The spectrum, so when we're talking about invasive aspergillosis, we're really talking about kind of the forms at on the left-hand side of the screen there, where you have significant angioinvasion in it, and the progression is over days, hours to days, really. The diagnosis can be complicated, so you might be lucky, and you might, at time of bronchoscopy, detect tracheobronchitis, which normally will give you a bit of a feel for invasive aspergillosis. The radiology, again, there are some typical findings, particularly in the neutropenic host. So nodules with halo sign or air crescent sign, particularly in recovery of neutropenia, is well recognized, along with cavitating disease. And mycological evidence that you would look for includes, you may look for histopathology, so sampling or kind of cytology. You may grow it in fungal culture, and galactomannan in blood or bronchoalveolar lavage. PCR is a more novel technique, and it's probably slightly less well validated on deep bronchoscopic sampling. And that's just an image. I think we can all identify that. Nodules with some ground glass surrounding them, the classic halo sign. And it's similar. I'm not going to go through this in huge detail, but again, it's considering the host factors, clinical features, and looking for mycological evidence. I think this is particularly interesting. This is from colleagues, from David Denning and colleagues in Withenshaw, and this is looking at the diagnostic yield in respiratory samples in patients, actually originally with chronic pulmonary aspergillosis. But along here, this is a comparison between CC is conventional culture, HVC is high volume culture, and that's basically when they take just all of the sample and just put it onto the Petri dish for culturing. And then there's quantitative PCR, and these are patients respectively. The bars are patients not on antifungal therapy and then on antifungal therapy, and you can see the sensitivity and the likelihood of a positive result is greatly enhanced if you have either PCR or even if you use high volume culture. And the great thing about high volume culture is it doesn't require any extra kit, any extra tests. You're basically just putting more of the respiratory sample onto the dish to culture and to incubate. And they tend to culture it for a bit longer. But this technique was pioneered by Withenshaw Hospital in Manchester in the UK and really improves the diagnostic yield on your respiratory sampling, because conventional culture is quite poor at actually culturing Aspergillus. Treatment of invasive aspergillosis should always be triazoles wherever you can, so voriconazole, posaconazole, and more recently isovoconazole, although amphotericin B is an alternative. It should be noted that echinocandins, although sometimes used, particularly by non-specialists, are not particularly helpful in invasive disease. While they're useful in chronic pulmonary aspergillosis, in invasive disease, they are really should be reserved for salvage therapy in combination with other agents. And the duration of treatment is typically around 6 to 12 weeks, depending on patient response, clinical response, and radiological response. And some special circumstances that are worth mentioning in aspergillosis: breakthrough infection in patients who are already on mold prophylaxis, so patients who have undergone hematopoietic stem cell transplant. Normally, that is a rare event, but if it happens, you should switch to an alternative class of agents, so particularly give amphotericin B. And if you have azole resistance, we normally use either combination agents or, again, use amphotericin B. That's probably me time. I think that's all I've got time for. Thanks.
Thank you very, very much.